Hello everyone, this is Vunami. Today, let's talk about acute uncomplicated appendicitis. Could appendectomy be avoided by using antibiotics exclusively? Our learning objectives are to discuss some of the sections of the clinical trial, the CODA trial, comparing the use of antibiotics versus appendectomy for patients with acute uncomplicated appendicitis. We will also look at the guidelines for the use of these antibiotics for this intra-abdominal infection, as well as discuss whether we should use this more often in clinical practice. Now, a simple uncomplicated appendicitis is defined as an inflamed appendix without evidence of perforation, abscess, or generalized peritonitis. Most patients with appendicitis undergo an appendectomy, which is a well-established, standardized treatment in the United States. In fact, in 2014, more than 95% of patients in the U.S. with appendicitis underwent appendectomy. Now, recent trials have challenged the dominance of this surgical approach by using antibiotics exclusively for patients in this patient population. So there's reconsiderations for the role of antibiotics by the American College of Surgeons, suggesting the reconsideration of antibiotics in the treatment of appendicitis. Now, there are early clinical trials that demonstrate that acute uncomplicated appendicitis could be treated with antibiotics safely in 70% of patients. Now, the trial design for our paper of interest, our paper of interest is the randomized trial comparing antibiotics with appendectomy for appendicitis. There were 8,000 individuals assessed for eligibility, and 1,552 patients underwent randomization, in which this is a non-blinded, non-inferiority randomized trial, looking at two different interventions, either appendectomy versus antibiotic 10-day course. The objective of the study is really to determine if antibiotics are non-inferior to appendectomy for the treatment of acute uncomplicated appendicitis based on the results of the health status measure. Inclusions include English or Spanish-speaking adults, 18 years old or older, presenting to the ER with confirmed appendicitis from a CT scan. Patients with an appendicolith were included in specified subgroups. So appendicolith is essentially a small stone in the appendix, and it seems that based on the results of this trial, that patients with an appendicolith has a higher risk of complications, which may result in an appendectomy. And I'll show the Kaplan-Meier plot for that soon. The exclusions are going to include patients coming in with a septic shock, recurrent appendicitis, being pregnant. The primary outcome is the 30-day health status, assessed through the EQ5D questionnaire, also known as the European Quality of Life 5 Dimensions questionnaire. The secondary outcome is the appendectomy and antibiotic group. So for those who are in the antibiotic arm, if they eventually get an appendectomy up to by the 90th day, then they will be put into consideration for a subgroup analysis. Now, the EQ5D questionnaire that you see here have 5 different components. The scores total range from 0 to 1, in which the higher score indicates better health status. The intervention for the patient, if we are talking about the antibiotic arm, the patient would initially go through with IV antibiotic for 24 hours, so either monotherapy ertapenem, cefoxitin, or combination metronidazole IV with ceftriaxone, or with cefazolin IV, or with levofloxacin IV. Now, for the remainder of the 10 total days after that 24-hour IV antibiotic, the patient can be discharged home with metronidazole oral with Cipro oral. Or the patient can be discharged home with metronidazole oral plus ceftonir oral. Now, in terms of the EQ5D questionnaire score, the patients are going to be surveyed by telephone, mail, or email 24 hours after discharge, and then again 1 week later, again 2 weeks later, and then again 4 weeks later. So 1,552 participants provided sufficient power of over 82% to rule out a between-group difference in the EQ5D scores as small as 0.05 points of the pre-specified non-inferiority margin. This is on the basis of follow-up data for 90% of the participants at 30 days. We'll also show the Kaplan-Meier plot to describe the incidence of appendectomy from the antibiotic group, as well as for those with or without an appendicolith. Now looking at the EQ5D results at day 30, we'll see the antibiotic and the surgical arm. It seems that the results are very similar at 0.92 and 0.91. Therefore, if it's not over the non-inferiority margin of 0.05, that means antibiotics are non-inferior to surgery in the EQ5D scale. Now looking at the cumulative incidence of appendectomy, you'll notice that this Kaplan-Meier plot shows that for patients with an appendicolith, so with the red line over here, you'll see that the patient with an appendicolith has a higher risk of getting an appendectomy by day 90. And actually, if you look over here on the top right corner, that 40% of those who has an appendicolith have received the appendectomy. So it means that they are of higher risk for complications that lead towards an appendectomy. And it's also important to note that for all the individuals in the antibiotic arm, that 29% of those individuals actually have gone through an appendectomy by day 90. So the strength of this analysis is just due to the fact that 90% of patients from the antibiotic group are adherent to the antibiotics, and that the main weakness is essentially that the study only followed up with patients for 90 days, up to 90 days. And this was too short to check for long-term complications and recurrence rates. Initially, the study wanted to go through with 2 years for follow-up, but due to the pandemic, 90 days was ideal to them at the time. Now, in conclusion, antibiotics were non-inferior to appendectomy on the basis of results of standardized measure of general health status based on that EQ5D scoring, at least in the short term. Patients with appendicolith were at higher risk for complications that lead to appendectomy compared to those without an appendicolith. And so I think that this study really provides relevance during the pandemic, even right now, as clinicians can weigh the risk and benefits for each approach. Because I think that for patients who are coming in with symptoms of suspected appendicitis, it depends on the situation, but it's really a shared decision-making scenario for clinicians and patients on whether or not they want to go through with the antibiotic route. And actually, it was very surprising to know that patients, when they were assessed for eligibility, only 30% of those patients agreed to be randomized into the trial. And that's a very small amount. And I think that it's because patients are well aware that appendectomy is the first line of treatment. It's essentially the standardized way to treat this condition. And it seems that for the most part, patients just want to remove the appendix when they are in intense pain. And so in patients who are going through the antibiotic arm, typically we see that these patients are going through the 24 hours of antibiotics before going into oral therapy. Now, should we keep doing that? Is that something we should do in future research, in future studies? Or can we just go with 100% oral antibiotics for these patients? Would that be a safe consideration? I think that maybe not, because patients might want to be observed for at least 24 hours to see if there's any worsening of their symptoms that could decide on whether or not they might have to go through with appendectomy. So I think that it may be necessary. In terms of the antibiotic duration, it seems that the duration for the antibiotic arm in this study is 10 days. I wonder if we can shorten that. So these are my references. Do you have any questions?